Hello everyone, this is Jingmei Lin. I'm a GI and liver pathologist at Indiana University. Thank ASCP for providing this opportunity to present this talk about hepatocellular carcinoma diagnostics. Liver biopsy is a fundamental tool in the management of a patient who have either medical liver disease or a mass lesion in the liver. To be diagnostic, liver biopsy requires a large enough size to comprise a representative amount of parenchyma tissue. So for this talk, first I'm going to focus on the tissue adequacy. According to American Association of the Study of Liver Disease and the British Royal College of Pathologists, both recommend a liver biopsy of at least 20 mm in length with the presence of at least 11 complete portal tracts. Ideally, a size of 30 mm in length is recommended. If a liver biopsy is less than 10 mm in length with less than 6 complete portal tracts, the biopsy is inadequate. The second requirement is the width of the liver core, which depends on the diameter of the biopsy needles. We know that the diameter of the portal tract is roughly 0.8 millimeter. Currently, there are 3 needles used for the liver tissue diagnosis: 16 gauge needle, 18, and 20. So 20 is the narrowest, which cannot cover the complete portal tract, so it's not recommended for the liver biopsy. 18 gauge needle barely cover the size of a complete portal tract, so it's okay. And the 16 gauge needle is the largest, which is recommended by both societies for a liver tissue biopsy. Here are 5 examples of liver core biopsies, and please decide which one is adequate. Basically, we are playing a game of long and wide. Sample A and B both contains long and wide core biopsies, so both are adequate. For sample C, although it was taken by a 16 gauge needle, however, it's super fragmented, so it's inadequate. Sample D is a short fragment, only 5 mm in length, so it's inadequate. Sample E, although lengthly is okay, but however was taken by a 20 gauge needle, which is narrow that cannot show the complete portal tract. So C, D, E are inadequate biopsy. Besides length and width, location also should be considered. So subcapsular and hilar regions are the areas that are not recommended to put a needle for liver biopsies, because those areas are well known to display variable architecture distortion and inflammation. So like the samples here. So although the biopsy appears long and wide, but because of those biopsies were taken from the subcapsular areas, those biopsies are not representative of the underlying disease and the overall architecture. So this is the caveat for the liver biopsy. Let's move on to the diagnosis of hepatocellular carcinoma. We know that not every single mass lesion in the liver is hepatocellular carcinoma. The mass lesion in the liver can be both benign and malignant, and each of those 2 categories consists of multiple entities. In the past several years, there is significant achievement in the imaging study for the diagnosis of hepatocellular carcinoma. So multi-physic CT or MRI is recommended as the initial diagnostic test for patients with cirrhosis. We know that liver has a unique double blood supply systems. It has both the hepatic artery and the portal-venous systems. So for example, in this MRI study, in the arterial phase here, which highlight by the strong dense signal in the aorta. In the arterial phase, the hepatocellular carcinoma shows a hyper-enhancement compared to the surrounding parenchyma. And it also shows this smooth, well-demarcated border, also called a capsule. In the portal-venous phase here, when the majority of the non-neoplastic parenchyma shows strong signals of the imaging dye here, the hepatocellular carcinoma, the signal is decreased. This phenomenon is called washout. And this features washout and the capsule of the tumor are very diagnostic for hepatocellular carcinoma. The diagnostic algorithm of hepatocellular carcinoma is established by the American College of Radiologists. It's called the Liver Imaging Reporting and Data System, in short, LIRAD. So in this system, the features of hepatocellular carcinoma, washout, capsule are taken into consideration with the size of those features, and also measure the threshold interval growth of those lesions. And the mass lesion is further categorized into LIRAD 1, 2, 3, 4, and 5 categories. And here, in the LIRAD categories, you can see that LIRAD M means this is definitely a malignant process, although not necessary to be hepatocellular carcinoma. For the LIRAD 5, it's definitely a hepatocellular carcinoma. LIRAD 4, probably HCC. LIRAD 3 is intermediate probability. LIRAD 2, probably benign. LIRAD 1, definitively is benign. Figure shows the diagnostic value of LIRAD for hepatocellular carcinoma. A mass lesion in the cirrhotic liver with a LIRAD 5 score, it has 94% of chance to be hepatocellular carcinoma. For LIRAD 4, there is a 74% of chance the mass lesion is hepatocellular carcinoma. So LIRAD system has strong sensitivity and specificity for the diagnosis of hepatocellular carcinoma. So multi-physic CT or MRI right now is recommended as the initial diagnostic test for patients with cirrhosis. However, for those patients without background cirrhosis or for those HCC diagnosis is indeterminate on imaging, liver biopsy is considered a gold standard for the diagnosis of a malignancy. And now, let's focus on the histologic diagnosis of hepatocellular carcinoma. Hepatocellular carcinoma has two important features. The first is that it shows the features of a hepatocytic differentiation. So this is an example of a well-differentiated hepatocellular carcinoma. So basically, it resembled the the background hepatocytes. It shows this trabecular and pseudoglandular growth pattern, and this is a tumor that can produce bile. And in some cases, you can find mammary dank inclusions in those tumor cells, which resembled the background liver in a NASH patient. And secondly, this is a malignant neoplasm, which means they show more malignant features like invasion, like increased NC ratio, and also shows the features that is lacking in the normal parenchymal background. For example, loss of reticulin framework and loss of the normal portal tract. Based on the morphology, hepatocellular carcinoma can be further classified into well-differentiated, moderately differentiated, and poorly differentiated. The diagnostic challenging basically are on the two ends, the well-differentiated and the poorly differentiated. So I'm going to talk more about the well-differentiated hepatocellular carcinoma. Dr. Rondell Graham will talk about the poorly differentiated hepatocellular carcinoma. The differential diagnosis for the well-differentiated lesion in the liver basically include well-differentiated hepatocellular carcinoma, hepatocellular adenoma, dysplastic nodule, microregenerative nodule, and focal nodular hyperplasia. So I'm going to talk about each of them in details. Here are two liver biopsies, and one of them is well-differentiated hepatocellular carcinoma, and another one is a benign entity. We can see that based on the morphology, the differentiation between them can be very challenging. So let's look at case number 1. So this is a 44-year-old female patient present mild abdominal pain, and her transaminase within normal range. CT showed multiple masses in the liver, and the largest is 3.3 centimeter. And this is the lower power wheel of her liver biopsies that shows 3 long and wild cores, which is excellent liver biopsy. The intermediate power wheel shows the lack of the normal portal tract, which means this is a neoplastic process. High power wheel shows minimal cytologic atypia. Mild steatosis is appreciated. Some areas shows isolated arteries without accompanying bile duct or portal veins. A reticulin stain is used that shows intact reticulin framework in those lesional cells. So taking together, this is a classic example of hepatocellular adenoma, which represent a benign hepatocellular lesion arranged in a regular place that shows minimal or no cytologic atypia. It can show isolated arteries without accompanying bile duct. Hepatocellular adenoma can be further classified into different subtypes. Although morphologically they can show more or less atypia, but however, the reticulin stain is intact, and morphologically they are different from the hepatocellular carcinoma. In contrast, a well-differentiated hepatocellular carcinoma shows more cytologic atypia. although sometimes it can be subtle, and in those cases, reticulin stain is very helpful. For example, here, the reticulin stain is lost in the hepatocellular carcinoma cells here. The caveat to interpret reticulin stain is when the parenchyma appears steatotic. For example, this is a hepatocellular adenoma with, in a subtype with steatosis. And here, the reticulin stain in those steatotic areas is lost. So don't overcount the loss of reticulin in those areas. Additionally, immunohistochemical markers can be helpful in the diagnosis of hepatocellular carcinoma. So here are a list of multiple immunohistochemical stains that we can use. So all these markers are most likely to be positive in the carcinoma. So they are called the malignant markers. But you can see here, none of them is 100% sensitive or 100% specific. This is the glypican-3 positive stain in a hepatocellular carcinoma. According to different studies, the sensitivity can be from 50% to 70%. The advantage for glypican-3 is that it's negative in hepatocellular adenoma. But however, I do have several cases which is well differentiated hepatocellular carcinoma and turn out to be negative in the glypican-3. So a negative stain cannot exclude the hepatocellular carcinoma. This is a table that summarizes the features between carcinoma versus adenoma. So morphology is the key. And carcinoma shows more cytologic atypia and high NC ratio. And reticulin stain and glypican-3 immunostain can be helpful. This is an example of a dysplastic nodule. So basically, dysplastic nodule is a pre-malignant lesion which has not have the definitive features of a malignancy. So it's a nodule that well circumscribed with no evidence of invasion into the surrounding parenchyma. It occurs in a cirrhotic liver, and it shows moderate to marked cytologic atypia. So like this one, this dysplastic nodule stands out compared to the other regenerative nodule in the background, which shows in the right lower corner here. Compared to the cirrhotic nodule here, the dysplastic nodule, those cells shows higher NC ratio, although that the nucleosides looks similar. So this higher NC ratio makes this nodule stands out, looks more crowded. Let's look at case number 2. This is a 40-year-old female with history of diabetes, and her BMI is high. Her ALT and AST are slightly elevated, and clinically, they think she has NASH. And CT shows a 4.5 centimeter mass in the left lobe of the liver, and a biopsy is performed. And this is also an excellent liver biopsy, 2 long cores, wide enough, and morphologically it shows some vaguely nodular formation. And here you can see that the hepatocyte here shows no cytologic atypia. The NC ratio is well formed, and the separating fibrous band here contains variable inflammatory infiltrate and multiple thickened wall arteries. And at the end here, ductular reaction is appreciated. And here in the other sections, the normal component of a portal tract is not appreciated. Instead, there is a ductular reaction. We don't see the hepatic arterioles. We don't see the portal veins architecture here. Syncytial immunosine shows a map-like pattern in the lesional cells. Together, this represents focal nodular hyperplasia. Focal nodular hyperplasia is a benign hepatocellular lesion that is arranged by cirrhotic band, morphologically mimicking cirrhosis. But however, this is a local event. It shows features of so-called pseudo-portal tract-like pattern, which might contain ductular reaction with loss of interlobular bile duct. The arteries within the lesion show thickened wall vessels, and there is no normal component of portal vein. And here is a summary of the microregenerative nodules, which occurs in a cirrhotic background. In compare with the focal nodular hyperplasia, cirrhosis is a diffuse process that largely involves a majority of the liver parenchyma. And morphologically, you can see different features based on the underlying liver disease. For example, you can see loss of bile duct or ductopenia in patients with chronic biliary disease. You can see mammary duct inclusions. You can see steatosis in patients with NASH cirrhosis or due to alcoholic liver disease. So today, we talk about multiple issues related to the liver biopsy and the diagnosis of hepatocellular carcinoma. So we want to spread the information to our clinical colleagues that the liver biopsy, if it's required, should be long and wide. And basically, our diagnosis is based on the materials that are provided by our clinical colleagues. And this information needs to be spread. As a pathologist, we take everything into consideration, including the patient's clinical histories, any underlying liver disease, if the liver is cirrhotic or not, any malignant history. And also we take into the imaging study into our consideration. So for example, even morphologically, it looks like it shows benign features, look like an adenoma. But however, if the patient is a male patient and has a cirrhotic liver, I always put into cautions into my diagnosis. I would mention something like well-differentiated hepatocellular neoplasm, C node, and then mention that an adenoma is extremely rare in male patient in a background of cirrhotic liver. So clinical caution for possible sampling errors of hepatocellular carcinoma should be excluded. So for our evaluation, HE is still the key. We just need to know when to use the reticulin and the special stents to help the diagnosis. And we also need to know the advantage and caveat to interpret those staining pattern. This is my last slide for this presentation. Thank you for your attention and patience.
I'm delighted to be sharing with you as part of this course. My name is Rondell Graham. I'm one of the GI liver pathologists at Mayo Clinic in Rochester, Minnesota. My presentation is entitled, What is my approach to the diagnosis of the poorly differentiated hepatocellular carcinoma? I'm partnering with Dr. Jingmei Lin, who's one of the professors of pathology at Indiana University. She presented the other half of this course, and I'll be presenting this portion. As I mentioned before, my name is Rondell Graham. I'm a professor of lab medicine and pathology. I'm the head of the section of GI liver pathology at Mayo Clinic in Rochester, and I'm involved in some other administrative roles there as well. So the diagnosis of HCC is really, or poorly differentiated HCC, is really an interesting challenge. And when you consider HCC diagnosis in general, it's really a tale of two challenges. The two major challenges are distinguishing well-differentiated HCC from its mimics, and distinguishing poorly differentiated HCC from other tumors that involve the liver. This latter challenge in the developed Western Hemisphere is influenced by the fact that there's a greater frequency of liver metastases or metastatic disease than there is primary liver malignancies in the West. The common metastases from the AFAP fascicle include carcinomas, most commonly from the lung and the colon, but also from other sites as listed here, malignant melanoma, and sarcomas. When we look at population-based data from surgical practice, unlike the AFIP cases which were from autopsy studies, we notice that again the most common carcinomas are from the GI side, then there are carcinomas of unknown primary, followed by breast and lung. And indeed carcinomas substantially outweigh melanoma and sarcoma, but again in the context of an individual case, you want to be cognizant of the fact that it is possible that the liver is involved by a tumor that is not a carcinoma. And so for that reason, I think the way to approach an unknown tumor in the liver is really to begin with trying to determine what's the line of differentiation. You want to distinguish hematolymphoid processes from carcinoma, melanoma, and sarcoma. Very, very rarely you'll encounter a glial tumor outside of the neuraxis involving the viscera. This is vanishingly rare. I've only seen 2 cases in my career, but far and away the other options are more common, or the other possibilities are more common, and it is really relevant to ensure that your initial panel and or your clinical evaluation excludes some of these possibilities before you focus on making the final diagnosis. So in general terms, I think it's important to use the clinical clues as much as possible. Some pathologists prefer to look at the slides and to allow morphology to influence their decision making first and then refer to the clinical information later. Others prefer to do this in the reverse sequence. I don't know that the sequence matters very much. I'll present to you the sequence in which I go through cases, but I think the critical thing is to consider all of that information. So first I begin by looking at clinical clues. A patient has a history of prior radiation to the site, may be at risk for radiation-induced sarcoma. Of course, those usually occur several years after the history of radiation. I'm always curious about the history of prior carcinoma, where it was, recognizing that a new primary is still possible. The same thing is true for malignant melanoma, and the same thing is true for GIST. So when it's possible, I like to compare the histology of any prior tumors with what is available presently. And it's also important to realize that even though these things are clues, they don't represent confirmation of any specific diagnosis. It's just information that you want to consider while making your interpretation. Next, I turn to morphologic clues. I'm looking at the tumor cells to evaluate for the presence of pigment. If I see melanin pigment, that would of course point in the direction of melanoma or a tumor that's showing melanocytic differentiation. But it's important to distinguish melanin pigment from other pigments, including hemosiderin, which is very common, and of course bile, which of course is specific to the liver. Intracytoplasmic mucin is another important thing to look for, and it's important to not overinterpret myxoid areas as evidence of mucin production. Keratinization points in the line of a carcinoma. And I think an important clue to at least have some clear guidelines in your mind about are the plasmacytoid neoplastic cells. These actually occur in a range of tumor types across lines of differentiation. So you can see plasmacytoid cells in hematolymphoid malignancies. Malignant melanoma can appear plasmacytoid. I've seen this with GIST. Of course, carcinomas can do it. So it's important to be recognized that plasmacytoid morphology is not specific for a particular line of differentiation. And along those lines, be aware that CD138 being positive can be positive in a range of tumors. And I've actually seen a number of cases in consultation referred as hematolymphoid proliferations that ended up being either GIST or carcinomas that were CD138 positive. Matrix production is a very compelling morphologic clue, and when you see that in the form of cartilage or bone, that provides strong evidence for sarcomatous differentiation, but you want to make sure that you're not overinterpreting collagen being present. Other morphologic clues that are really helpful and things that I look for consistently, I'm looking for an in situ epithelial component. An in situ component suggests a carcinoma, and it's important to be cognizant of the pitfall about metastases colonizing the surface. Small round blue cell tumors can include tumors of all types, but I think it's important to pay attention to the degree of pleomorphism. In general, carcinomas tend to be pretty pleomorphic, certainly high-grade carcinomas. Hematolymphoid neoplasms and melanomas tend not to have the same degree of pleomorphism, and that can be a helpful clue. The nature of the vasculature is helpful. If you see HPC-like or hemangioparasitomatous-like vasculature, that will be unusual in a carcinoma. So pay attention to the pleomorphism, pay attention to the vasculature. The age of the patient is helpful, with certain age groups being more likely to have sarcomas. And then where is the tumor located? The epicenter is often helpful inflammation as well. Certainly a growth pattern that appears so-called fibrosarcoma-like will suggest a sarcoma, although sarcoma-type carcinomas can do it as well. And an HPC-like pattern is more characteristic of a sarcoma than other things in the differential diagnosis. Now again, I want to emphasize that clues are not the same as confirmation, but this schema that I've just presented to you over the last 3 slides are helpful sets of clues that help me as I look at the morphology and begin to consider the immunohistochemical findings. They help to refine the interpretation, and I think I can't overemphasize how important it is to pay attention to these morphologic clues. I will say in general, paying attention to these clues can reduce errors and certainly begin to point people in the right direction. Now, while I've talked about a lot of general things here at the outset, I think we're going to delve into more specific details in the slides that follow. But I want to mention again that these general details are really helpful because tumors that present in the liver are not guaranteed to be liver primaries. And as I mentioned before, in the West, they are more likely to be metastases. And this kind of broad framework and background is really helpful for efficient and accurate diagnostics. So in terms of HCC specific clues that I think are important to be cognizant of, the first is that cirrhosis increases the likelihood of HCC, but it doesn't exclude metastasis. And if you see bile production, that's evidence in favor of an hepatocellular carcinoma because no other cells in the body make bile other than hepatocytes. Now, hepatocellular carcinoma has a heterogeneous appearance within tumors and across tumors, and this by itself can be a helpful interpretive clue because it's pretty common as you look through multiple slides of an HCC resection to see different morphologic patterns cytologically and even architecturally. So that by itself is a feature of HCC and something worthwhile looking for. But again, just something to be aware of, HCCs look different even across tumors. Now, the WHO has a criteria for HCC grading, and those criteria are pretty intuitive. I don't list them in specific detail here because there are other grading systems, like the Edmondson grading system. Some of you may be familiar with that. But using the raw criteria for the WHO, which I think are really helpful, well-differentiated HCCs tend to look like normal liver. Poorly differentiated HCCs look malignant but require immunohistochemistry to confirm a hepatocellular phenotype, and moderately differentiated HCC is somewhere in between these extremes. I think that grading system is helpful, and even in our own practice, working with my colleagues in research projects, we have shown that it is prognostically valid, with poorly differentiated tumors doing worse than moderately and well-differentiated tumors. So I think it is this system proposed by the WHO in the most recent 5th edition is clinically and prognostically useful. There are a couple limitations, though, that I want to point out, because I think that these will be helpful in your practice. The first is that it's subjective how one applies these thresholds. So it's subjective. Where do you stop being well differentiated and move into moderate? It's subjective where it is no longer looking like normal liver, and it's also subjective as to when something requires immunohistochemistry to confirm that it's a hepatocellular phenotype. You'll see a range of interpretations about that from various pathology experts at an individual case level. So there's some subjectivity to the threshold, which means that people will have different thresholds for what they call well differentiated and what they call poorly differentiated. Be that as it may, the reality is that most liver pathologists call almost all cases moderately differentiated hepatocellular carcinoma. I think it would be fair to say that realistically about 80 to 85% of HCCs are called moderately differentiated. But I think that is a helpful framework just for you to be aware of, and from there we're going to turn our differentiation, our attention rather, to the poorly differentiated hepatocellular carcinomas. So I'll illustrate with 3 cases that I think are really helpful. Some variation of poorly differentiated hepatocellular carcinoma as interpreted by expert pathologists in our practice. Here's an example. This was a hepatocellular carcinoma, somewhat mimicking a well-differentiated neuroendocrine tumor because of the nested pattern of growth to it. But this was a case that was interpreted as being a poorly differentiated or moderate to poorly differentiated. Here's another case interpreted as poorly differentiated. This one perhaps more convincing than the previous for being poorly differentiated. But again, another hepatocellular carcinoma. You can see that there's some large pleomorphic cells with bizarre nuclei away to the right-hand side of the field, and in this particular case having some clear cytoplasm. But like the previous, showing convincing expression of all hepatocellular markers and a lack of expression of markers of other origins. And the third example is a tumor here with more anesonucleosis, and so the pleomorphism from cell to cell is perhaps more pronounced in this case, with a bizarre atypical mitosis almost in the center of the field. And as you see, showing, I think, pretty convincing high-grade cytologic features. And I think what I've been able to illustrate for you across these 3 cases is that poorly differentiated HCC can look like a lot of different things. And so I think this underscores the importance of these prior steps I mentioned, those prior morphologic steps and clinical clues, but also the important role of immunohistochemistry. And if we turn to the next set of slides, I hope I can confirm to you that the algorithmic approach is best. Here's a tumor that is characterized by large eosinophilic neoplastic cells. You have a big unpaired vessel in the center of the screen, and in the middle portion, the cells have abundant eosinophilic cytoplasm, somewhat granular in appearance, with a fair amount of intratumoral hemorrhage. But when you look at the arginase, then this case was negative for arginase. It was also negative for hePAR. It was sent in consultation as an HCC that happened to be negative for arginase and hePAR. But if you look at the center panel really carefully, you'll see that there's some spider cells here, where you have the condensation of cytoplasm centrally, with these almost tentacles of cytoplasm or thin threads of cytoplasm extending out to the cell membrane. And this particular tumor is positive for both smooth muscle actin and melanocytic markers. This is actually an angiomyolipoma. And so this is an example of a pitfall seen in routine clinical practice, but it also is an example of a pitfall that I've seen multiple times in my practice, and this is angiomyolipoma being mistaken for hepatocellular carcinoma. underlying, I think, the importance of immunohistochemistry, but also careful morphology and interpretation. So again, this is an angiomyolipoma, which mimic hepatocellular carcinoma. So I think it's helpful to point out now what I think is a safe stepwise approach to diagnosis, and hopefully it's becoming clear why I spent some time in the beginning focus on the line of differentiation and these morphologic clues. I think you want your immunohistochemical panel to first establish a line of differentiation. I like to use these markers listed on the slide: Oscar and AE1, AE3 to confirm a carcinoma, S100 and melanin A to rule out, maybe not rule out, but certainly to evaluate for the possibility of melanoma, and the other markers to evaluate for other lines of differentiation. Of course, the clinical picture and the morphologic features influence what may or may not make it into that first panel, but this is a broad approach that I think is safe to make sure that we don't miss any of the lines of differentiation. Now, I want to emphasize here that there are some important challenges that need to be considered, particularly in the interpretation of keratin expression in high-grade tumors. It's important to pay attention to the clinical context, background neoplasia, the location and pattern of growth, cytomorphology, and the complete immunophenotype. Older patients are more likely to have carcinomas, of course, but not necessarily. Cirrhosis suggests HCC, which often has a trabecular pattern of growth, but can show other patterns of growth. Pleomorphism is very common in HCC, as I pointed out previously, and it's important to interpret keratin in the context of the full immunophenotype. And I emphasize this in blue at the bottom of the slide. I'm going to use a couple cases to illustrate what I think are some helpful considerations. So this is a case from a 65-year-old man showing a neoplastic neoplastic proliferation that is really monotonous. High power, you can see, is a pretty monotonous neoplastic proliferation. There is substantial mitotic activity. You can see some mitosis even in the center of the field here. It has a conspicuous vascularity to it, with the neoplastic cells divided into trabecula. And in some places, you can even appreciate here in this field of view, there's some bizarre nuclei with some nuclear regularity, pretty hyperchromatic. Highlighted in the blue circles are some pink eosinophilic inclusions that I think are some helpful clues in retrospect. But this is a case that was submitted as a hepatocellular carcinoma in our practice, and one of the contributors to it was that it had some degree of heparin expression. One of the giveaways that we disclosed when we worked this case up a little more was it was pankeratin negative, and it was negative for CAM 5.2 as well. An additional workup confirmed expression of inhibin and synaptophysin. This was in fact a case of adrenocortical carcinoma mimicking hepatocellular carcinoma, a really important mimic to be cognizant of. I have seen this pitfall multiple times in my practice, and a lot of it is due to not properly or carefully or thoroughly working cases up, and I think this highlights the importance of a keratin in the workup and not over-relying on a heparin alone. So I've seen both adrenal and right-sided renal masses misinterpreted as liver masses by radiologists, and so the pathologist can follow the garden path as interpreting sampling of the adrenal and the kidney as hepatocellular carcinoma, because on morphologic grounds alone, these can be close mimics, and the immunohistochemical panel, if not done thoughtfully, can allow the pathologist to continue down that garden path. So it's important to be aware of these possibilities. This slide highlights the most common mimics of hepatocellular carcinoma. Things sent as poorly differentiated hepatocellular carcinoma. These are the most common ones that I've seen in our practice. The first is prostate carcinoma, which has a similar 7 and 20 profile to HCC. But if you're aware of NKX 3.1 and PSA and you do those markers, those will often help you. A similar thing applies for renal cell carcinoma, of course in this case using monoclonal PAX8. I like to use arginase over HepAR1. It's a more specific hepatocellular marker in our hands, and I find albumin-ish to be highly sensitive for hepatocellular carcinoma. And indeed, if a case is negative for albumin-ish, I will be very cautious about making a diagnosis of HCC. Synaptophysin and chromogranin are really helpful in excluding well-differentiated neuroendocrine tumors, and also mucin stain can be really helpful in excluding the possibility of hepatoid carcinoma. I showed you an example of adrenocortical carcinoma, that particular pitfall, and the immunostains we use in that particular case. And I've included melanoma in this slide because, again, that's a pitfall that I've seen. I like to make sure that keratin is positive before I make a diagnosis of hepatocellular carcinoma. So as in the example I previously showed you, just looking at H&Es and a HepAR alone, especially Apache REAT HepAR, that alone won't cut it for me. I like to be more careful in my interpretations and make sure that keratin is positive. I think I've convinced you to use special stains by now, and I think it's crucial to understand their limitations though. So here's a case of a 60-year-old woman with a liver mass sent as a hepatocellular carcinoma. I'm sure it has big pink neoplastic cells. There's some clear cells in the background. There's some there's some anisonucleosis or nuclear size variation. So not morphologically terrible for hepatocellular carcinoma. And indeed, HepAR1 was convincingly positive. But if you look at the mucin stain here, lots of intracytoplasmic mucin. This is a hepatoid adenocarcinoma from a patient with a prior gastric mass. And in this particular example, arginase was completely negative. So a hepatoid adenocarcinoma may mimic hepatocellular carcinoma. I'm often looking for intracytoplasmic mucin and true gland formation as helpful clues. Now, even though hepatoid adenocarcinomas are from the stomach and GE junction, and so they're often positive for CDX2, it's important to beware relying on CDX2 expression as an exclusion criteria for hepatocellular carcinoma. And the reason for this is that aberrant CDX2 can be seen in hepatocellular carcinomas. This was presented by some colleagues from our group in 2017. And you can see here some excellent colleagues in 2021 expanded on this observation, showing that CDX2 and also other markers that you associate with intestinal differentiation can be positive in hepatocellular carcinoma. In fact, CDX2 is positive in almost 4% of hepatocellular carcinomas in a diffuse way, meaning more than 50% of the cells, but CDX2 can be positive in more limited or to more limited degrees in additional percentages of hepatocellular carcinoma. So you need to be aware of over-relying on CDX2. I think it brings us now to hepatocellular markers and some important words that I'd like to share regarding those. So arginase 1 is the hepatocellular marker, single one of the IHC markers that I really like. I prefer it to HepAR because you can see here, when you consider all the HCCs, arginase is strong and diffuse in almost 90% of those, whereas I think HepAR1 is strong and diffuse of the order of 65%. This is in the hands of those colleagues at the University of Chicago. I think HepAR is probably strong and diffuse in a greater percentage of cases in our practice, but arginase definitely shows a greater sensitivity. Interestingly, when you look at poorly differentiated HCCs, which is the real area of challenge here, you'll see that arginase is positive much more frequently than HepAR is, strong and diffuse. You can see here arginase strong and diffuse in about a half of such cases, HepAR in a little less than 15%. So I find arginase to be a more reliable marker when we come to poorly differentiated HCCs, and just across the board is just a more sensitive marker, and I find it to be more specific too. you'll notice that if you look at the expression of heparin-1 arginase across non-hepatocellular tumors, you'll see uncommonly, but definitely, heparin-1 is positive in lung. You can definitely see it in quite a bit of GE junction adenocarcinomas, but you can see it also in colon cancers, as they've pointed out here in their particular study, and of course most frequently in gastric adenocarcinoma. By contrast, arginase is much more specific. Just one example here in a prostate cancer. And as we use these markers more and more, we find that their specificity is less than in the initial studies, but indeed, I think arginase is a much more specific marker in our practice as well. People will sometimes ask about polyclonal CEA and CD10. Candidly, I and many of my colleagues rarely, if ever, use these markers. If they're submitted to us, we will offer an interpretation on them, but I'll say that I rarely use them. I almost never order them myself, and from observing my colleagues in practice, I would say that that's true of them as well. Glypican-3 is a marker that we use much more commonly though, and I'll turn my attention to that in the next few slides. So glypican-3 is an oncofetal antigen, so it's not expressed in normal liver outside of a couple contexts. If we focus on the context of a mass lesion, in the context of a liver mass, it isn't specific to hepatocellular lineage, but is a feature of neoplasia. It can be expressed in germ cell tumors, gastric carcinoma, and placental neoplasms, so it's important to interpret again IHC in context. But why it is helpful, glypican-3 that is that it is positive in hepatocellular carcinomas, and would argue that a hepatocellular lesion, mass lesion, positive for hepar, is likely to be malignant. You can see these data from Hanlin-Wang published a few years back showing that it is diffusely positive in about half of hepatocellular carcinomas in their study, in this particular study, in a diffuse pattern, and positive to smaller degrees in a lower percentage of hepatocellular carcinoma, but negative in about a quarter of them. So a negative glypican-3 does not exclude HCC. And you can see some degrees of expression and different patterns of expression away in these 3 panels to the right. Interestingly, when you look at glypican-3, it is positive most commonly in those that are moderately, or let me say they had more moderately differentiated cases in their particular study, and those that were moderate and poorly differentiated were more likely to be positive and strongly and diffusely positive. Glypican-3, of course, though, is negative, not infrequently in well-differentiated HCC, seeing fully about a third of them were negative. But moderate and poorly differentiated, which is our focus here, you'll see that these are commonly positive, but indeed can be focal. When Hanlin-Wang and his colleagues looked at needle biopsies, they found that this is where the rubber meets the road, and it is important to be really careful in one's interpretation. Looking at poorly differentiated HCCs, 4 of them were negative on needle biopsy. And when you look at the fact that there were only about 8 meeting that particular grade, it means that about half of the poorly differentiated HCCs may be glypican-3 negative on needle biopsy. Small numbers, so I don't want to overestimate those conclusions, but the important point is that on needle biopsies, a negative glypican doesn't rule out hepatocellular carcinoma, although a positive result certainly would. We support that interpretation in the context of a mass lesion, and where the other hepatocellular markers are positive as well. I want to turn our attention to albumin in situ hybridization because I think this is a highly sensitive marker for hepatocellular carcinoma. Only hepatocytes produce albumin protein, and while I would say that this marker is not 100% specific, as I will point out on some subsequent slides, its sensitivity is really, really high, and the data from Sanjay Kakar which were published, this is a long time ago, 20 years ago, when he was at Mayo Clinic at that time, showing a sensitivity of the order of 92%. When you look at the more modern platforms here in our practice, now you can see looking at 22 HCCs, albumin positive in 100% of them. And I would say in our hands, albumin is a very sensitive marker for hepatocellular carcinoma. And so I like it as the most sensitive of all of the markers. But importantly, it is not 100% specific. It can be expressed in astronocellular carcinomas, as you can see here in this particular table, and it can be positive in a number of other adenocarcinomas, as we showed in this study published by one of our excellent former fellows, Dr. Axel Nasir, just a couple years back. So my preferred hepatocellular markers are arginase and albumin-ish. Key contributing markers are glypican-3, and I like to do reticulin and Ki67 as supportive markers for malignancy, but in the case of poorly differentiated tumors, that's usually not the question. Usually the markers, the preferred markers, and the key contributing markers are what we are going to be focusing most of our attention on. There's absolutely nothing wrong with doing HEPAR once you're cognizant of the pitfalls associated with the marker. We don't use polyclonal CEF very much in our practice. We have the marker, but we don't use it. And there's some other canalicular markers like bile salt export protein that others may use. But as I mentioned before, our preferred ones are those that I mentioned above. A key thing to consider in making the diagnosis of poorly differentiated hepatocellular carcinoma is to distinguish it from cholangiocarcinoma. And to do that, I tend to look, again, at everything in context. You have to look at clinical information on morphologic features. Of course, if you see intracytoplasmic mucin, as shown here in the middle of the table, that will support the interpretation of a cholangiocarcinoma. And of course, if you see true glandular differentiation as well. But looking at the markers, just the markers, so assuming that the other findings were equivocal or not differentiated, Keratin 7 is not a very good differentiator because it's positive in a significant minority of hepatocellular carcinomas. Keratin 19, so too, is positive in a significant minority of hepatocellular carcinomas. Intracellular mucin is a helpful distinguishing feature, particularly for extrahepatic and hilar cholangios. Intrahepatic cholangiocarcinomas, especially the small duct type, are frequently negative for mucin. Arginase is very helpful because it's often positive in hepatocellular carcinomas. Albumin is helpful in confirming that it truly is a primary hepatocellular neoplasm when it is strong and diffuse. The loss of BAP1 is really helpful because it's more often lost in cholangiocarcinomas in about a quarter of cases. It can be lost in hepatocellular carcinoma, but that's less common. There are other tools that can be helpful. Those tools are really related to molecular testing. It can be helpful because the common HCC mutations, TERT promoter, beta-catenin mutations, ARID1A, NFEL2 mutations, those are more common in hepatocellular carcinomas. The mutational profile of cholangiocarcinoma tends to be different. Intrahepatic cholangiocarcinomas, which are the ones most likely to mimic HCCs, may show IDH1 and 2 mutations in about 20% of cases, FGFR2 fusions in about 10% of cases, BRAF mutation in another 5%. You may find BAP1 mutations, and also you may find less commonly KRAS mutations. Those are more common, of course, in the extrahepatic, but the mutational profile is quite different from what is commonly seen with HCC and could help make that distinction in cases that are particularly challenging. Again, BAP1 mutations rarely will be found in cholangiocarcinoma, uncommon in HCC. And if you see mismatch repair deficiency, which is very uncommon in both types, you're almost certainly, though, in that instance, dealing with a cholangiocarcinoma because it's vanishingly rare, if not almost never reported in HCC. So what about combined cholangio, HCC and cholangio? This definition requires clear glandular component and HCC components based on the morphology alone. So you need to clearly be able to identify those two components. And then the immunohistochemistry is supportive, but doesn't override the above requirements. There's some imaging data from Europe on artificial intelligence and novel markers that are poised to influence the field. They're outside the scope of what we're going to discuss today for routine practice. But I think it's important to recognize that you need to get to this diagnosis based on morphologic features first, and then apply HCC. And then apply IHC. So the preceding slides, I think, will hopefully have provided you with enough information to really recognize true HCC components and true cholangiocarcinoma components. So with that, here is my proposed algorithm. For making a diagnosis of poorly differentiated HCC, I'm looking for a tumor that has a high-grade cytologic features. Usually there's quite a bit of nuclear polymorphism and particularly convincing abnormal nuclei. I think it's important to confirm epithelial lineage. I've shown you my two key markers of epithelial differentiation, and then I confirm hepatocellular differentiation, usually with arginase and albumin-ish. It's okay to use hepa and polyclonal CEA. Sometimes, depending on the context, you may end up using various combinations of these markers, and I think glupican-3 may be confirmatory, and I certainly would do it in addition to these in terms of completing the picture, depending on the clinical context and the available information. I think it's important to emphasize that you want to confirm the lineage, that it is a carcinoma, and then interpret this in the context of the full panel based on the prior slides that I showed you and the available clinical information. So to summarize, I think a safe approach to diagnosing poorly differentiated HCC includes establishing an epithelial lineage and hepatocellular differentiation. Thoughtful use of immunohistochemistry and in situ hybridization can avoid diagnostic pitfalls. Common mimics are cholangiocarcinoma and carcinoma of unknown primary. Adrenocortical carcinoma and renal cell carcinoma are two mimics to be careful of. And molecular testing may be helpful in some cases where the differential diagnosis is really challenging. And with that, I'd like to thank you for your time. Thank you so much.